in our country, not very many people do, but those that do. Should we do anything to the tumor in the breast? Because we normally think of the tumor, of getting rid of the tumor in the breast to prevent its seeding to cause metastatic disease. But if you already have metastatic disease, does it do any good to remove the breast? And there are several non-randomized trials that have been presented over the last decade suggesting that maybe it does good to remove the breast even in the presence of metastatic disease. And Dr. Badwe is going to present one of the studies, randomized trials that attempts to more definitively answer that.
Thank you, Dr. Osborne. On behalf of the Breast Cancer Working Group at Tara Memorial Hospital, I'm presenting this data, which addresses the results of randomized clinical trial, which looks at removal of the primary tumor and axillary lymph nodes followed by radiotherapy in women who present with metastatic breast cancer. The conventional wisdom believes that these women should have surgery only if there is impending fungation or bleeding. In routine course of events, they are not offered treatment for locoregional disease. To support this has been the norm for many, many years. To support this, there are studies, very elegant experiments performed by Dr. Bernard Fisher between years 1979 to 89, which did show that the removal of the primary tumor might just be detrimental, and I'll talk about it a bit later. But in the last decade or so, as Dr. Osborne mentioned, there have been many studies, all of them retrospective, at either institutional level or at registry level, which have looked at the survival of patients who have had surgery, and they have shown, in fact, there is a systematic review of these studies which shows a 35% reduction in deaths in patients who have had surgical intervention. I must warn that all these studies were retrospective and fraught with selection bias. Coming back to Fisher's experiment, Dr. Fisher did this experiment wherein he produced a primary tumor in mouse and allowed it to grow to a certain level, and then created, using the same cells, a second tumor. So the second tumor was assumed, into inverted commas, as metastases. He then went ahead and removed the primary tumor and found that there was a growth advantage to the second tumor, which was termed as metastases. So there was something happening by the event of surgery which was increasing the size of the secondary tumor. So the house was divided, and hence this trial, which addresses the issue of effective removal of primary tumor and axillary lymph nodes. The primary endpoint was overall survival, and the secondary endpoint was locoregional failure versus, as well as distant failure of disease-free survival. We looked at women presented with metastatic breast cancer. There were about 400 plus women who were onto the log. They received either CEF, anthracycline-based chemotherapy, 6 cycles, or 4 cycles of CEF followed by 4 cycles of taxane. And of these 400, those who had complete response or partial response, so only responders were included in the trial. Those were 350 in number. They were stratified by site of metastases, the number of metastases, and hormone sensitivity, following which they were randomized to receive either locoregional treatment or no locoregional treatment. There were 173 patients who were randomized to locoregional treatment, and they had either a breast conservation treatment or a modified radical mastectomy based on the extent of the local tumor, and a complete axillary dissection, and that was followed by radiation to the chest wall or breast, as well as the peripheral glandular areas. Those who were hormone sensitive and menopausal also had ovarian ablation, surgical, or radiation castration, and they continued on tamoxifen. And those who were postmenopausal were put on aromatase inhibitors. On the other side, there were 177 patients randomized to locoregional treatment, and they had exactly similar systemic treatment if they were hormone sensitive. That's the overall survival. and there is nothing much to look at. They are one on top of the other, very identical survival. The median survival time was about 18 months, and it did not, there was no difference in survival at all. When we look at the secondary endpoints, within this primary endpoints, we tried to look at, is there any subset that benefited or otherwise, since there was a 4% excess which did not reach statistical significance. So we're trying to see if there is any subset that was harmed or benefited, and there was nothing to choose again, whether it was menopausal status, metastatic sites, whether number of metastases, hormone sensitivity, or HER2 positivity. None of them had any difference whether surgery performed or not. So uniformly, no difference at all in any subsets. The secondary endpoints were locoregional progression and huge difference, more than 80% control rate in those who had surgery. I must say that about 10% of the patients who were randomized to no locoregional treatment did undergo surgery. To be precise, the number was 18, and that was either for impending fungation or pain in the breast. So that was entirely palliation as thought of in routine course of events. Now the question that begs an answer here is such a huge difference in local control, why it did not translate into overall survival benefit. And the answer was the distant progression-free survival was diametrically in opposite direction. There was a 42% excess progression, rapid progression seen in the arm that had surgical intervention. So there was a kind of trade-off. Although there was an over 80% local control in women who had surgery, in the same subset of patients, there was a rapid growth of distant site disease, which obviously canceled out all the benefit of locoregional control. To conclude, the clinical conclusion would be that locoregional treatment of the primary tumor in women presenting with metastatic breast cancer did not result in any overall survival benefit, and hence should not be offered as a routine practice. The biological fallout of this study is that surgical removal of the primary tumor in these women appears to confer a growth advantage on distant metastases. The findings that were found in a Fisher experiment in the early 80s and mid 80s is in fact first time seen in human studies. I acknowledge the brave women who participated in this study and the support of the Clinical Research Secretariat as well as the Clinical Trials Center at Tata Memorial Hospital, and funding source was Department of Atomic Energy, Government of India. Thank you very much.
Hi, Caroline Helwig-Gasco Post. What time period was this trial conducted?
2005 to 2013.
Okay, so now there's so many available drugs for metastatic disease. How wouldn't that influence the outcomes? And also another question, maybe to Dr. Osborne, is that 18, let's see, the median survival time 18 months in line with other studies of current treatments?
Well, majority of the patients have received on progression whatever standard of care. The drugs used are anthracycline-based therapy followed by taxanes in hormone-resistant patients. And if that failed, they've gone on to receive Gemcite and platinum-based. So the standard of care has remained exactly the same. The only difference would be in about 18% of these patients who are HER2 positive, they have not received Herceptin.
Okay. Hi, Neil Osterweil with Medscape Medical News. A question for Dr. Osborne. You said we don't see too many women with metastatic breast cancer these days in the United States, but what is the standard of care for those women who are seen?
Well, there's two issues in patients with present with metastatic disease. The one thing is, can we do something to improve their survival overall? It's an incurable condition. Can we improve their survival? And we've done pretty dismally at that. We have new drugs, we have other things that can sometimes prolong survival in individual patients, but overall, we don't do well in patients with metastatic disease, so we're still trying to improve that. The other issue is, what do you do about the tumor in the breast? And there's two issues there. One is, in some patients, particularly in the older years when we used to see big tumors that would come in, the patient would have a terrible infected, fungating, bleeding mass on the chest wall, and that's a terrible way to live, or in this case, die of a disease. And so, in many cases, mastectomy was done to relieve those and to give palliation to such a patient. And then we saw that in some of these retrospective studies, those patients that had that procedure seemed to do a little bit better. And that begged for then a randomized trial to see whether it really does improve survival or not. And this trial suggests that it doesn't. That's not to say that we shouldn't do mastectomies in the appropriate patient, but this trial would argue against doing it as a routine in all patients, but maybe perhaps only those patients in whom there is going to be a cosmetic problem on the chest wall with a large infected mass. And there you do the surgery to give the patient palliation. So I don't know if that
Yes.
would agree with your thoughts, but that's
The
what I think.
control arm did have surgery in about 10% of them. So not all of them progressed to impending fungation or pain. So those who had, they did have surgical intervention in the form of a mastectomy.
Dan Keller, Oncology Times. I think Dr. Osborne may have just answered part of this, but these trial results sort of create a dilemma. Do you want distant progression, or do you want local regional control with distant progression, or not? I suppose the local regional control gives a better psychological effect, a better cosmetic effect, and gets rid of the fungating and potential for infection, but there's no change in overall survival. Can you actually recommend or advise women which way to go?
As I mentioned, the 173 patients who have been, 177 who have been randomized not to receive loco-regional treatment, only 10% of them needed surgical intervention to obviate the quality of life issues. The rest of them did not have any quality of life issues that they complained about.
Charles Bankhead, MedPage Today. This also is a question for Dr. Osborne, but as you noted earlier, it's not very common for women to have metastatic disease at initial presentation in the U.S. So how applicable would you consider this study to the situation in North America, for example?
The numbers that were presented this morning, it's about 5 to 10% of patients presenting with breast cancer have metastatic disease at presentation in this country. In India, it's about 10 to 15%. So it would be about 1/10 of the patients who present, and that number has not changed over a period of last decade or so, whether it is this country or India.
Can you give us some hypothesis on how removal of the primary tumor can influence the growth of the metastases?
Well, there are lots of possibilities. The first and the foremost is that surgery itself, event of surgery or act of surgery might elaborate some growth factors which might allow the distant metastases to grow. The second possibility, which was suggested by Dr. Fisher, is that the primary tumor, which predates the onset of distant metastases, elaborates some inhibitory factors, and that is not there once the primary tumor is removed, bestowing that autonomy of growth onto the distant metastasis once the primary is removed. And the third possibility is the act of surgery itself might induce some more metastatic process by dissemination and create new disease. All these three possibilities exist. In the Fisher experiment, they had identified a factor which could suppress the tumor growth subsequently in some of them.
Would you
Dr.
agree with that,
Fisher's-
Dr. Osborne? Just wondered if that fits with what you would think about the mechanism.
No, I think no one knows for sure, but those are the hypotheses. What Dr. Fisher showed us, when you have a mouse that's got metastatic cancer in the body and the primary tumor, you take out the primary tumor, then you measure the growth rate in the metastases, it grows faster, suggesting that the primary tumor has some inhibitory effect. And we've known for a long time that tumors grow rapidly, and then when they reach a certain volume in the patient, they plateau and they seem to grow more slowly. And so maybe in a patient with lots of metastatic disease, they're at that plateau, they're growing more slowly. You remove some of the tumor to get rid of the primary tumor, and now you put them back down into a lower volume, and now they're able to grow faster again. That could be part of it, but exactly what it is, the factor in the blood that's released or whatever, still not known.
Dora Schmidt from Germany, German Breast Cancer Association. I often talk to women and they want the tumor out in the adjuvant setting, and I'm just thinking here whether women were being integrated into the decision making. In your case, could you maybe refer to that?
This is not a curative surgery. We're not talking about adjuvant treatment. All of them receive surgery when it comes to curative intent. This is a set of patients wherein cures are not possible at this juncture with whatever kind of treatment we can offer. In such events, patients were explained that this is what the present data that we have available. Would you like to be part of this study? They have consented for it, and there are about 9 out of these 173 who were randomized to loco-regional treatment. They refused to have loco-regional treatment. And there were 3 on the other side who have asked for treatment, and they did receive treatment, although they were randomized to no loco-regional treatment arm. But essentially, as I mentioned, patients would take a call for removal of the tumor if it was troubling them. And a great majority, these are responders. After having received 6 to 8 cycles of chemotherapy, a fair number of them would have either a complete disappearance of the tumor or hardly anything felt. And the perception that further surgery is required or not was not so very great in these individuals.
And that does have to be our last question because we're just about out of time. So on behalf of the sponsors of the San Antonio Breast Cancer Symposium, thank you to the participants and the members of the